Hey there, it's Rob Arnfield again. This is going to be a good one. We're talking about left ventricular function. We approached left ventricular function in a goal-directed fashion, as we do with many of the other aspects of point-of-care echocardiography. And it's important from the outset to say that it's not practical for us to measure ejection fractions at the point of care. It's a time-consuming method that uses multiple views that we don't often achieve at point of care. The exact number that we often get attached to in assigning an exact 35%, 42% ejection fraction, while it's a bit soothing to us, we like exact categorization like that, it's actually entirely irrelevant and misleading. By way of example, if you have a hyperdynamic left ventricle with a 80% ejection fraction, the entire stroke volume might only be 20 cc's, which is incompatible with good organ perfusion. So an ejection fraction that might seem reassuring may be entirely associated with a adverse hemodynamic state. So let's get rid of ejection fraction. Let's talk about goal-directed LV function assessment. The eyeball method is the prevailing method we will use. It's very accurate with practice, which you'll have during this screencast as well as during image interpretation sessions at the course. And it relies on broadly classifying the LV into probably four basic categories. Is it really good? So hyperdynamic. Is it normal or within a degree or two of normal? Is it bad? Or is it terrible? What you do with this information will vary based on your clinical scenario. And an ideal way of thinking about this is if you consider the Surviving Sepsis Campaign guidelines, which have their many flaws for many reasons, but one of them is they prescribe 30 cc's per kilogram for all comers that roll through your doors who have severe sepsis or septic shock. And though these clips are playing a little bit slowly, I hope I can convince you that patient B here has very robust LV function with the parasternal long axis showing the endocardial excursion and myocardial thickening being very good, mitral valve opening, and we're going to review all these findings shortly. It's a normal heart as compared to this heart, patient A, which has very marginal LV function. And you can see that broadly classifying the differences between these two, not prescribing them an exact EF, is enough for you to recognize that patient A is going to have a much stormier resuscitative course than patient B, which is really what we're after, rather than just assign them a ejection fraction. So the three things, as I already sort of spilled the beans, that we look for when we look at LV function is endocardial excursion, myocardial thickening, and mitral valve movement. So let's unpack this a little. So here's a cartoon of the parasternal long axis where these three features of LV function are highlighted. That we look at endocardial excursion. So does the heart muscle move toward a centric point in the cavity or the LV chamber? Does the actual myocardium, does the muscle actually thicken throughout? And as a corroborating finding, as we'll review, does the mitral valve leaflet, does it open widely, suggesting that lots of blood is passing through the mitral valve, which is a reassuring feature of good LV function. So these are three things you're going to try and tune your eye to as we go through a variety of examples going forward. So here is an example of normal LV function as seen in the parasternal long axis. Anatomy-wise, we have the RVOT, the LV, the mitral valve, the left atrium, the aortic valve, the descending aorta, the pericardium, and the pleural space. And here we have all three of those features we just described. We have endocardial excursion, so the septal wall and the inferior wall are moving towards the middle of the cavity. The muscle itself is thickening, so there's myocardial thickening taking place, and the mitral valve opens nicely, and the anterior leaflet here even comes into contact with the septum. So this is nice, normal LV function, a bit tachycardic, but the function itself is normal. So we've talked about the mitral valve a little bit. I just want to explain this finding a little bit more because the muscle moving in the right direction is a bit more intuitive than this is. So mitral valve excursion, also known as EPSS or E-point septal separation, it's an old concept. If you go back to cardiology textbooks from the 50s, you'll find this mentioned. And it's a really neat idea that really the heart as a closed system means that what goes in past the mitral valve has to go out the aortic valve. So if the mitral valve opens fully and vigorously, it means generally there's a lot of blood passing through it, which means that in a closed system model, a lot of blood must be leaving with each cardiac cycle as well. That's sort of the simple broad brush strokes of it. And the best way to see it is usually on the parasternal long axis view, where you can appreciate the proximity of the anterior leaflet to the septum. And if it does approximate the septum, then generally LV function is going to be good. And if it doesn't, it's likely poor, though there are some false positives which we'll review with respect to that. So here's an example of end diastolic mitral valve in that example of severe LV dysfunction I showed you previously. So look at the distance you can see here between the septum and the anterior valve, mitral valve leaflet. It's a significant distance, whereas the normal example I showed you, you might recall that the septum and the anterior mitral valve leaflet were nearly touching each other. So this is an example where a small amount of blood is entering into the left ventricle and a small amount of blood is leaving, hence the mitral valve is not opening widely. The other thing that causes diminished movement is that as the ventricle fails, it dilates typically, and it pulls on the papillary muscles, and it doesn't allow the valve to open more fully. So there's a few different mechanisms at play, but this is a helpful corroborating finding. I wouldn't say use it in isolation. Use it as sort of a reassuring check once you've decided based on the other two parameters, endocardial excursion and myocardial thickening, whether you think the LV function is good or bad. Now, there's a few pitfalls of this method with using the mitral valve, and if the mitral valve itself is diseased and stenotic, that's going to natively cause the valve to open poorly, independent of the circulatory status. And aortic insufficiency can also cause that mitral valve leaflet to open poorly because of the jet that washes backwards over it. Prosthetic valves are, of course, non-starters. And if the septum itself is quite large, then it comes to encroach on the leaflet instead of the leaflet coming to it. So structural heart disease overall is going to be an area of concern for you. And the other thing, of course, is that if somebody acutely decompensates, so is having a myocardial infarction and they're having severe LV dysfunction, the changes in the circulatory status, the changes to the left ventricle that often lead to restricted valve opening do not have time to set in. So do not use it in isolation, again, is my overall advice. So this is back to that normal example again, where you see that valve opening nice and fully, in addition to the other findings of thickening and excursion that we've now mentioned several times. So how about this one? So have a look at it. You can see it's a parasternal long axis view, and looking at those three features. So you're looking at does the endocardium, does it move towards kind of a centric point, like where my mouse cursor is? Does the muscle itself thicken? And you can see, you can appreciate thickening here in sort of the basal septal area, and maybe a little bit, in the inferior wall as well. So, there's a bit of thickening. And what about that mitral valve? Does it approximate the septum entirely during end diastole, or is it a little bit reduced? And so this is one of the hardest echoes to call in general in terms of categories, because this is probably somebody who has reduced function, not normal, not severely reduced, but kind of in the middle, that bad ventricle that probably isn't going to, in isolation, cause critical illness, but may complicate your resuscitation and may complicate things. So this is the middle of the road, sort of moderately depressed left ventricle. And how about this one? Now, again, thinking just right away, you may have an immediate gut reaction to this clip, which I think is a good sign. And most people, when they look at this, will immediately recognize the LV is pathologically dilated. The muscle here does not thicken nor move significantly towards the middle. And the same is true of the other wall. And the mitral valve opens poorly as well, as the clincher for the fact that this is a more severe form of LV dysfunction and would fall in the severe dysfunction category. So what do you think here? We have another parasternal long axis view, a little bit overgained, my apologies. You have the endocardial excursion of the two walls to look at, the thickening of the muscle, and the mitral valve to look at. I'll give you another second to form your opinion. And if you were suggesting that this heart might be a little bit in the too good or hyperdynamic category, you would be right, because you have end systolic obliteration of the LV cavity of the walls actually touching each other, and for additional reassurance, the mitral valve is opening widely. So this would be somebody with hyperdynamic ventricle, perhaps on 2 inotropes, or hypovolemic, or in an afterload reduced state, depending on their clinical scenario. So here's those 4 examples sort of side by each, again, just for your rapid review. I'll give you a moment to look at those examples and think about those 3 areas of analysis for these echoes in the parasternal long axis. Okay, so we're looking now in the short axis. What do you think of this one? So you have a peristernal short axis, which is a much more intuitive view, I think, overall to interpret LV function because of the fact you have all four walls. And in this view, it's best to just put your cursor or your finger on the screen and have a look and see how the walls are coming together. Again, this is a patient who's tachycardic, so the tendency is often to overcall these ventricles and say they're hyperdynamic. But hyperdynamic hearts in the short axis, the papillary muscles should really come into contact with each other, which they don't here. And so I would say that all four walls are contracting reasonably well. They're thickening, they're moving towards my mouse without being hyperdynamic, so I'd call this a normal left ventricle. And how about this one? So again, a short axis view, reasonable contraction of the ventricle, but not quite as vigorous as the last one, and so this would be a moderately reduced left ventricle. And this one here, again, may evoke similar visceral negativity as the previous severely reduced ventricle. You can see that there's actually is some thickening and submovement, but that it's globally reduced in a severe fashion. So this would be a picture of severely reduced LV dysfunction. This one should be easy. This is a great example of a hyperdynamic ventricle. You see here in the short axis tachycardic, the papillary muscles are smashing into each other. It's a very typical example of a underfilled heart. For bonus points, you see a small amount of pericardial fluid as well. So once again, we'll let you look at these three examples in the peristernal short axis. Probably my favorite view for assessing LV function because of the fact that it doesn't fall into doesn't have the pitfalls associated with the peristernal long, which we reviewed in the echo views lecture. So again, hyperdynamic, and you have normal, depressed, and severely depressed. So we'll give you a few more examples just to give you added confidence. So peristernal long axis view, what do you think here? So thickening, excursion, mitral valve movement, check, check, and check, normal ventricle. Okay, short axis view, you don't have the mitral valve to look at, but is there thickening and good excursion, moving all towards the center of the LV cavity? Yeah, good, or maybe even too good, so this would be on the hyperdynamic spectrum. So a peristernal long axis view we have here, and again, you're going to pay attention to excursion, thickening, and mitral valve movement, and this is an example of a hyperdynamic ventricle. Another one here, you have walls moving the wrong way during systole, something called dyskinesis, but ultimately the LV cavity changes almost marginally in size throughout systole and diastole, and this is a critical degree of LV failure. And that same view in the long axis, again, it doesn't require a lot of analysis to recognize that this is an importantly depressed ventricle in the severe category. So that's it, guys. That's really what it comes down to for LV function, in those two views in particular. And those, I think, are the two best views to assess LV function. Doing so in the apical and subcostal is certainly achievable, and you will do it. Though if you have your druthers, I would take peristernal views or the subcostal short axis as a stand-in for the peristernal short axis if you can get it. Remember, we don't need calipers. You just need your eyeballs. Lumping the LV into those four categories you reviewed, I think, is the most helpful construct clinically. It allows you to make practical clinical decisions without being overwhelmed by various gradations of LV function. You can be as accurate as a cardiologist as the literature has shown with some practice, and this will help tailor your management of shock states for the critically ill. So I hope that helps, and we'll move on to RV function next.